Welcome to In a Heartbeat. I'm Liz Aiken. This is WMTV. Coming to you from the studios of the Grosse Pointe War Memorial. We are in Grosse Pointe Farms, Michigan. This show today is with a doctor whom I've known for forever, just about. And really we've been talking back and forth about doing this show for quite some time. It is about male health, male sexuality, you'll see. My doctor's name is Tom Mertz. He is a gem, and I am like, man, I'm so pleased you're here.
Oh, it's a pleasure to be here, Liz. Thank you.
This is so fun.
Yes.
And you and I are catching up in the hallway, talking about this and about that, and then it really comes down to, let's just get this thing going.
Yes.
So, thank you.
I can't walk through the ICU without coming into contact with you, almost on a daily basis.
Yeah, you're not kidding. So Dr. Mertz, Tom Mertz, you are a urologist. And your group's name is, please? Comprehensive
Medical Center. We're actually Grosse Pointe Urology, a division of Comprehensive Medical Center, which is a large group. We are located in all around the city, in the suburban area, from Westland, Troy, West Bloomfield, Royal Oak, Clinton Township, and Grosse Pointe.
Excellent. So this is a large group.
Yes. Yeah.
And you've been in the business for a while.
30 years. 30 years in private practice, yes.
And you've seen a lot of things come and go. But we're going to talk about really what the trends are. What are you seeing? What are actually some of the things that people have heard about a long time, but things are new? We got like a whole new ball game on some of these things, and that's what we're going to cover today.
Well, there's a lot of new information coming out about erectile dysfunction, and associated with hypogonadism. There's new guidelines about PSA testing and screening for prostate cancer. There's important information that I feel would be useful to families, individual, about prostatic enlargement, lower urinary obstruction, and the need to consider intervention in a timely fashion, and finally stone disease, urinary stone disease.
And you know, seriously, when we get to that part, and that's really going to be in the last segment, we're going to talk about kidney stones. It's so interesting, but I love anything to do with the kidneys, how they function, how they operate, what is going on with them, and I think people never realize that the kidneys themselves are some of the most unbelievable filters ever. I call them the Uber filters. And so I'm really pleased that you could be here to talk about this. And we're going to start right off with male metabolic syndrome. And I have to preface this by, when you hear about people who say, oh, you know, I feel like I get home from work, I hit the couch, I don't have the energy to do anything, or the spouse is saying he doesn't have the energy to do anything, he doesn't want to visit with us, he doesn't want to do the same things he wanted to do. When it comes time to get into the bedroom, he's so uninterested, or you know what, he just doesn't show up until I'm fast asleep. And you hear that, and there was actually an article in the New Yorker quite some time ago with Jerome Groopman talking about this, and you read this, and Proto-Mag had a piece on this, and you read this and you go, oh my God, this exactly describes my husband, myself, whatever, whomever it is. What is going on with this?
Well, there's a Dr. Guy out of Harvard University who put two and two together when it came time to looking at the male patient who is hypogonadal, failing sexually, and has some of the related symptoms such as lack of drive, pep and energy, and also he associated with type 2 diabetes, hypertension, hyperlipidemia, high cholesterol, and the two and two together, in high body mass index, that's the one thing I omitted. There's a lot of things to consider in the syndrome. So you're looking at a guy who may get to a urologist who has other conditions, but his main urologic complaint is, I can't perform sexually.
Can't perform.
Right.
And which is crushing. It's crushing to everybody.
Well, exactly. So you look at what's going on with them medically, and you say, well, you have some hypertension. Are you taking medications? Of course they are. They're on a list of medications that people move into because of their situation, and because of the disorders that are being managed. Because they're diabetic, we may attribute that to, the poor sexual function to the diabetes, rather than go right to the are they deficient in testosterone?
Right there.
Yeah, exactly.
And it could be literally as simple as that. And then there, like you say, there could be other attributing factors, but to now know to look at that specifically.
Well, getting a testosterone, getting a first morning testosterone, and double checking it if it's low, will tell you that yes, there's a coincidental problem going on here. And then you have to consider hormone replacement therapy or testosterone replacement therapy to help them through that. But getting to the root problem, you know, it is there's a lot of obvious things that if a person changed, such as limiting their diet, losing weight, going back to exercise, that I think that the body would restore itself and get, you know, and some of the elements of the syndrome, such as type 2 diabetes, the hypertension, if that could be corrected, if the hyperlipidemia could be corrected, they probably reverse that trend, find more energy, and be able to, you know, have a higher quality of life, and sexual performance would follow.
So it's really, you look at the guy and you think, it's like an old dog, and you look at maybe your old dog is laying on the couch, on the floor, you know, wherever next to you, and you go, I'm just like this old dog. But that doesn't have to be. It is literally. No. Check some really basic lab tests or whatever, see what it is, and then think about replacement. And it's like a new lease on life.
Well, absolutely. But you get a person that you're deciding to perform hormone replacement therapy on. There's some things that need to be considered. It's just not an automatic decision, because they should be seen by a urologist. Their prostate needs to be checked. Their PSA has to be in a normal range. And then once you give them the hormone replacement therapy, you have to reassess, see if you're gaining the desired outcome for them.
Yeah, exactly.
Yeah.
Right. Isn't it, it has to be so comforting for a person to come in. But first of all, they just got to get in.
They
not
have,
just
they
think
have to
this
come
is the way it's going to be.
Right.
No, that's not right. They need to get in.
That's it. There's no substitute for acknowledging a problem and then going to the proper person to solve it in terms of maintaining quality of life.
Right. Now, we were talking about the subjective versus objective. About the objective is literally, what is that level? You subjectively think it's this or it's this, but what is physically the level that they're dealing with?
The numbers we're going to throw out are what are considered normal levels for testosterone. A male in their 40s and 50s should have a testosterone level of 500 or greater. So, but you don't need a lot of testosterone to be able to function. What we consider low is a testosterone below 300, and truly hypogonadism and the related problems to that come with testosterones below 200 in the range of 150 or so.
Right. And then that's getting really low. So even to keep them up into a basic range, sometimes you're just literally like touching them up a bit.
That's right. That's right.
Easily.
Yeah. And testosterone replacement can be through two methods. There's the transdermal agents that go on by patch, or gels or creams that you rub on a daily basis. They're very convenient. Some people react to the carrying agent, like the gel, they get a rash from it, and they object to that. Or you can give the IM injection of testosterone about every 3 weeks, 200 units.
Side effects from?
You just, hopefully the side effects are positive.